Thank you so much for the invitation to be a part of the Advanced Valve Therapies 2025. And today I'm going to talk about the tips and tricks for mitral transcatheter edge repair, anatomy and imaging. And my name is Julie Grapsa, and due to the difference of time, this lecture is recorded from Brigham and Women's Hospital. So, once again, I would like to express my gratitude to Dr. Iakovou and Onassis Cardiothoracic Surgical Center for the invitation. As we know, the guidance for transcatheter intervention is distributed in pre-procedural, which is important for patient selection, intra-procedural and post-procedural. And in brief, it has to do with the anatomy, the assessment of scallops and commissures, because mitral valve can be complex. Also, if appropriate, to classify the valve according to the Carpentier classification, to identify, to select between clefts and indentation, and then we need to know about our surroundings, such as LV dimensions and left atrium, and also any left atrial appendage, spontaneous epicontrast, and of course we proceed to the Doppler measurements. As we know, the mitral valve is rather complex. Yes, it has two primary leaflets, the anterior and posterior, but as you will see, it's separated into the anterolateral commissure, the posteromedial commissure, the anterior leaflet, posterior leaflet, and they have 3 scallops each. And we usually aim to give the surgical view to the interventionalist with the help of imaging. And then also you will see that there is important this intercommissural diameter, which affects the diameter of the mitral annulus, but also the height. And it's important to understand the remodeling of the mitral annulus depending on the pathology of mitral regurgitation. When I say use your all senses when you visualize the mitral valve, because it's important to understand that we have the scallops, the mitral annulus, and it's important to give the precise location of the involved leaflets. Very commonly, we see A2P2 involvement, and this is where, for example, the clip is quite more easier than if we have A3P3 or A1P1. And then it's important to describe the presence of an extent of calcifications, if any, because that poses a challenge in the anatomy for edge repair, and then to separate if we have any indentation versus real cleft, which would be a contraindication actually to a mitral edge repair. And as we know, the Carpentier classification, that type 1 is when we have poor leaflet coaptation, such as dilate annulus from atrial fibrillation or restrictive cardiomyopathy. Then frequently we see now that we do edge repair in type 2, when we see, for example, like Barlow's or papillary rupture, and a lot of our patients are type 3B, which is ischemic heart disease, the functional mitral regurgitation, and of course sometimes dilate cardiomyopathy. Starting from the basics, and of course the first step, even when the patient is on the table, we need to do an anatomic assessment of the mitral valve. And we start from the mid-esophageal between 0 and 20 degrees, that we have the 4-chamber view, and then we see A2P2, and then we proceed to this commissural view, that 60 to 80 degrees, and then of course we have 90 degrees that we see a whole extent of the anterior leaflet. And of course, the last one is the 120 degrees to 135 degrees that we usually see A2P2. Depending on the pathology, this is a very easy view in order to be our guide for clipping. And then, of course, we alternate between 3D and MPR. Here, this is the surgical view that we see the scallops A1, A2, and 3. And then posterior scallops. So we always position the aortic valve on the top, and we need to be fast, and of course select usually multiple cycles in order to have a good frame rate on the left. As you can see here, it's 18 Hz. It's important to understand the limitations for when we assess mitral regurgitation, because when we have multiple jets, and especially an eccentric jet, then the accurate assessment is rather challenging. And many times we will use the 3D vena contracta with multiplanar reconstruction, which seems that it has a great sensitivity and specificity to assess the severity of mitral regurgitation. Remember that here we have the 3D vena contracta needs to be more than 40 millimeters per mercury, and it depends a lot whether the regurgitation is primary or secondary. For example, when we have functional mitral regurgitation. But we need to take into consideration that the orifice, while it's circular in primary mitral regurgitation, is non-circular, and it's many times elongated across the mitral coaptation line in secondary mitral regurgitation. Then we usually assess the pulmonary vein systolic reversal. However, with many times patients will have atrial fibrillation and elevate left atrial pressure, and it creates blunting. So I have not really seen that we have real flow reversal, with only very few cases that the patient is in sinus. Most times that we see blunting, and usually we use it when we have, for example, the mitral regurgitation that is borderline, and we want to confirm that, of course, it's severe with the systolic reversal from the pulmonary venous flow. And of course, if we have the continuous wave Doppler that's quite dense or dagger shaped, then it's we understand that the mitral regurgitation is pretty severe. It's important also to understand the left atrium, the involvement, and of course, we never forget the right heart, because the pulmonary pressures will be elevated when we have chronic mitral regurgitation, and of course, the left atrium will be dilated in patients with chronic AF, for example, all these patients with chronic remodeling of the left ventricle. So this is important to understand the pathology and also the process of having a chronic mitral regurgitation. When it comes to edge-to-edge repair, first, a very important step is the transeptal puncture and the guide catheter insertion, and then the positioning of the guide catheter and the delivery system. Then a very important role as the leaflet grasping, the leaflet insertion assessment and the clip closure, and then the deployment and assessment of the device post-procedural. So, as we said, step one is the transeptal puncture and then the catheter insertion. When we assess patients before on the table for mitral edge-to-edge repair, it's important to understand the suitability for edge-to-edge repair, which is an ideal anatomy here with a flail gap less than 10 millimeters, with a mitral area for more than 4 and no calcification. While actually, if we have mitral calcification and then complex anatomy, then the patient may benefit more for a mitral valve replacement rather than repair. This is a patient that I want to show you how we are performing the transesophageal echo on the table, and immediately we assess the patient, because we need to assess again the right heart, the anatomy and etiology of the mitral valve, the mitral regurgitation, and of course the left atrial appendage. And here it's important to understand about few qualities of the good transeptal puncture. We help the interventionalist in order to go to the posterior superior aspect of the fossa ovalis, and when we have degenerative mitral regurgitation, more than 4 centimeters above the mitral annulus is ideal, while 3 to 4 centimeters we use for functional mitral regurgitation. And here is a great central illustration from JACC Interventions from this review paper from Mohammed Al-Kulif in 2006, that you will see practically the qualities of 3D transesophageal echo that helps us guide the transeptal puncture. And it visualized the real anatomical aspect of the interatrial septum, and then we measure directly 3.5 to 4 centimeters or more than 4 when we have degenerative mitral regurgitation. So here we start. We actually, here we have already done the transeptal puncture, and we assess in order not to cause any trauma to the left atrial appendage, and then we guide the system insertion into close to the mitral valve. Here is, you will see that the system has been inserted, and then we guide, rotate the edge-to-edge repair device. And then it's important to use the aortic valve as a guide. So we have we use the LVOT view, and then with X-plane we use the commissural view, and many times we will alternate between the 3D and MPR in order to position the clip. Many times we will go between 12 and 6 o'clock, and this will affect, of course, if we have an A2P2 prolapse, then we will see that this clip is perpendicular to the mitral coaptation line, and it would be ideal in order to have an excellent outcome. Here is how we optimize the leaflets, either separately or together, and we do staged leaflet capture in order to, and we are making sure that we will see both of our leaflets at the perfection from all sides. So if we have any doubt, then sometimes the intervention may want to use ice in order to see better the leaflets, or of course alternating views between mid-esophageal and then going to 3D and then multiplanar reconstruction, the MPR. Now then we deploy the implant and then we adjust it in order to have the best possible outcome, and of course not to create any significant stenosis after the implantation of the edge-to-edge repair device. Now we are looking importantly the flow assessment, so we definitely make sure that there is no iatrogenic stenosis. This is a mitral clip insertion that gives a mean gradient of 3, and this we don't want it to be more than 5. And also we use transesophageal echo for the positioning, and if it needs repositioning, in order to have, as I said, the best possible outcome. And then we have an algorithm that I will show you on how to assess the clip and of course the regurgitation post-device deployment. Here is an example of to the extreme that this is a patient that they inserted actually 3 different clips, and then they did also a plug. You can see the clips and the plug that, of course, here you would expect that the gradient across the mitral valve would be significantly high. This is a very comprehensive algorithm that was published in the Journal of American Society of Echo, that you will see how to assess residual and mitral regurgitation after percutaneous mitral valve repair or replacement, and I would advise you to have a look. So, but however, we need to remember the traditional parameters such as effective orifice area or regurgitant volume. If we have more than 2 jets, we need to use our eyes and all actually measurements in order to provide an accurate assessment. So sometimes when there are complex jets, and especially around the device, these parameters may not be that accurate to assess mitral regurgitation. As a take-home message, after we separate actually all the steps, pre-procedural, to have an excellent assessment of the patient, and of course choose the right device for each patient, intra-procedural and then post-procedural, it's important to keep in mind the value of heart team for optimal selection of patients. The post-procedural mitral regurgitation should be graded using an integrative approach, and it's important it's to be similar to the pre-procedural echocardiographic baseline assessment. That may sound repetitive, but using the same protocol will save you actually from mistakes. And of course, the post-procedural assessment is challenging. However, a good echocardiographer will actually give a precise information about the nature of the jets, of the residual jets, and the severity. And of course, hemodynamics are an important step in the guidance of further management of this patient. With that, I would like to thank you so much for your attention.
It was a very didactic and pragmatic contribution to the topic. I believe that
it was a great presentation, a beautiful overview. Really, it's always helpful to remind us the procedural steps and how to obtain optimal imaging. And most importantly, assessment afterwards, which is always a difficult thing to do, to assess residual MR, and we have to really be very detailed in our analysis. Especially nowadays that we try to decrease MR as possible with one device as possible. We often try to reposition, optimize to get the maximum benefit with the first device before we consider a second device.
I believe also that it's a different task, apart from the quantification of the MR, concerning the organic versus functional MR. In the organic MR, we have to be sure that we have accomplished the anatomic reformation, restructure, whereas in the functional MR, quite often it is the different mechanism which might evolve during the procedure. And at the end of the day also, we should be aware that we need pressures of the LA, the final judgment, especially in the functional MR, because quite often, I'm sure that you have this experience, quite often with the anesthesia, during the intervention and before the final outcome, the amount of color is misleading. So we have to be aware of the pressures themselves in the LA.
Exactly, and it's not only echocardiography that will guide us in terms of success of the procedure, but also hemodynamics. And sometimes I've been in cases that if the hemodynamics don't improve, you really have to wonder whether your strategy and the position you put the device or what's wrong. So, and maybe reposition a different way to improve your hemodynamics. Even though color might look better, if hemodynamics persist, then you have to sort of go back to that.
Okay, and comment from the audience? Okay, so we have to proceed